Good morning, Dr. Dove.
Good morning.
We are here with Dr. James Dove. He is the president of the American College of Cardiology. This is one of the most important society of cardiology in the world. And we would like to know your experience. But first of all, I want to thank you to visit us in Argentina and to share us our principal meeting in our country. I like to ask you, how do you see the quality of attention of the patients in United States? And if you look in this meeting, some difference what would happen in Argentina, and what do you think that we may improve about the quality of attention, Dr. Dove?
Well, I think that what you see at a meeting such as this is that we have the same problems, is that cardiovascular disease is the #1 cause of death in the United States, as it is in Argentina. And so we need to solve those problems. And the difficulty is that the more technology we have, which improves patients' lives and allows them to live longer from heart attacks and strokes, the more costly it becomes to continue to take care of them. And every country in the world that I've visited that is developing or developed has that same issue, and we need to figure out how to solve that problem. So we have to deliver the best quality care. What I've seen at this meeting, which is not surprising, but is very clear, is that the quality of medicine in Argentina is superb, and the quality of this meeting is outstanding. And so it's really been a pleasure to be here, and it's an honor to be here. Because it's such a great meeting. And ACC is privileged to be able to partner with the Argentine Society to put this meeting on with you and put several sessions together. So it's really an honor to be here.
Oh, thank you very much, Dr. Dove, for your concepts. But do you think that the technology really will improve the quality of life of patients, or there are another things that are very important, like the advanced technologies to the patient to be better?
Well, I think the issue is that technology is spectacular and it's going to continue to improve. When I talk to industry, nearly 80% of the products or drugs are driven by what physicians have requested for patient care. So the companies will tell you that the physician input and the patient need is sort of the driver of what that technology is. The issue is trying to deal with prevention and improve prevention in our societies. The problem is that the payoff from prevention is a long-term project. And people have trouble adhering to prevention in the first place, so we need to help our patients do that. But also we need to have the governments and the insurance industry in the States particularly understand that prevention has a payoff. It's just way down the road. When we look at what's happened to death in the United States from coronary disease, it's down 60% from what it was in 1970. And the death from stroke is down 80%. So those patients continue to survive and continue to do well, but the other issue is they also continue to consume resources. And most patients will say, I'd rather live than be dead, of course, as long as I have quality of life. But they continue to cost the system money. So the real proof would be to try to prevent the disease in the first place, and that's expensive in a long-term project.
Do you think that the United States have really an economic problem with the new technology because the medical doctor use it improperly, and they use in cases that they don't need to use, and they spend not so much time in the office with the patients, and if they make more questions and better physical examinations, they don't need so much technology. Probably the cost will decrease. Do you think that's is the way?
Well, I really think that we probably do use technology maybe more than what it should be, But all technology, whether it's a new drug or a new device, always has this curve of where there's a lot of people using it, and then once you sort of define better who benefits the most from that, then the curve drops off to less use. What happens in the U.S. Society, the United States patient is very impatient, and they want the newest and the best, whether we're talking about refrigerators or automobiles or drugs or devices. And they're not very patient people. And so if I said to a patient, we can see you in 3 weeks or 4 weeks, they would not be happy with that. They want to be seen tomorrow. In fact, there are many practices in the United States that have sort of open scheduling, meaning the patient can call this morning and be seen this afternoon. And they have places in their schedule to allow that to happen. But that's dealing with what the patient wants. And so the insurance industry has promoted that. So rapid access is what they want. Now, also I can tell you that the insurance industry in the United States also forced us at one point that only interventional cardiologists could do a diagnostic cath and not just a cathing cardiologist. And what they wanted was to have the stent placed right at the time of the first cath. So insurance also drove that decision making. But now that's all turning around. And so I think as we saw some of the issues with drug-eluting stents, that we're going to see some cutback in technology, as we already have seen, and probably better and more appropriate use.
I think that another important issue is how much the people must know about cardiology. I saw in the newspaper a lot of information. For instance, sometimes some trials appears before in the newspaper than in the journals.
Right.
And do you think that is, has a good or bad impact in the population?
I actually think it has a bad impact. I'm all for having the patient be informed. But I think what they don't understand is the scientific process as you and I understand it. I mean, you have a lot of data that's presented, and then it may change next week or the next trial 2 or 3 months from now, and then you may be doing something different. After the COURAGE trial, which was presented in the United States at the last ACC meeting, many of the media came up to me and said, how is this going to change your practice tomorrow morning? Well, the answer is probably not. It's going to be something that I will evaluate and then decide how it changes my practice. But we have the media pushing that. So the media also is very impatient. But you also hit on a sore point of mine, which is the issue that I don't think the media should have the information before the scientific community. And that's the way it happens in the States right now. There's a huge push by the journals and some of the investigators to be on TV a lot. So.
Well, and for finishing, the last question is, could you summarize to us how is your medical practice usually in the United States? What do you do usually?
My medical practice is I practice in a group of 45 cardiologists, and we're in a small town in central Illinois, 100,000, but we draw from all the rest of the state, so we have a drawing every about 2 million. And so it's 45 cardiologists, and we practice what we still call compassionate patient-centered care. So we're very concerned about patient-centered care. And everyone practices in that same sort of format, is the patient first. We have a lot of physician extenders that help us do that. So we have 60 of them in our practice that help us do that, along with the 45 cardiologists. But the patient's number one. And so we don't function on an assembly line schedule. Patients come in, and whatever the appointment time is what it takes to take care of the patient. So I'm pretty proud of what our practice has been able to do with that.
Thank you very much, Dr. Duff.
Thank you, Oswald. Very good. Thank you.